My name is Jessica Heyer and I'm a pediatric orthopedic surgeon. So I commonly treat all different types of spinal deformity. That includes idiopathic scoliosis, whether or not it's early onset or adolescent idiopathic scoliosis, kyphosis, like Scheuermann's kyphosis, congenital scoliosis. But in addition to that, I also take care of pediatric fractures. So any fractures around in the lower extremities or upper extremities are fractures that I'm happy to see. Sometimes patients are diagnosed in their early adolescence, so 11 or 12, and so we really follow them throughout their entire growth period. That's really when scoliosis likes to flare up and continue to progress. And so we start with observing them up until a certain point when their spine is at a certain threshold, then we start bracing them. One of the nice things about scoliosis is that it's actually one of those diagnoses where you continue to have a relationship with a patient throughout their childhood and young adulthood and even into their early adulthood because you're monitoring the progression of their spine and their deformity. If they do get to a certain point about needing surgery, then that's when we start to discuss surgical options. But the other side of things is the patients who are diagnosed with what we call early onset scoliosis, so patients who are under 10 when they're diagnosed. And this can be getting the diagnosis at age 1 or 2, or it can be getting the diagnosis closer to age 8 or 9. And so we really try to do everything we can to avoid surgery in these patients. We do casting and bracing and observation if it's appropriate. But then if we have to, we start to talk about surgery that is more growth friendly. So it enables the patient to continue to have growth in their spine. What I will say is that the biggest challenge in treating pediatric spinal deformity is that every single patient is truly different. Every patient, based on their age, based on how much growth they have remaining, based on the size of their curve, what pattern their curve takes, really requires a different type of touch and a different type of management. My approach to patient care is very family-centric. I'm very cognizant of the fact that a child is still in school, they still want to do all the activities that they want to do, whether it's gymnastics or basketball or just running around and playing on the gym equipment with their friends. And so I really try to take into account all of those things when I'm trying to make decisions, but it's really not unilateral decisions that I'm making, it's decisions that I'm making with the patient and their family members to do what's best for them and what's best for whatever condition that they have.